Hello, I'm Dr. Verma. Welcome to the Dementia Doctor. So in this particular video, we are going to answer the question, what is the most ideal journey for a dementia patient through the healthcare system? Now, you may ask, how are you thinking about it? Well, if you know my story, I was initially trained in child neurology, but I had my own family member suffer from dementia and I served as a caregiver. And that is what inspired me to go into this field. But as I started working in the field of dementia, I would think from the perspective of a healthcare provider. But a few months ago, I started doing this thought experiment of what would it look like and what would be the most ideal scenario if I was again a caregiver and I was walking through the healthcare system with my grandmother who was diagnosed with dementia. So in this video, we are going to kind of do that thought experiment together. So before we think about an ideal situation, we have to think about what is the current standard of care or what is the usual practice. So say you have your loved one who is experiencing some kind of memory thinking problems. You notice that, you bring it to their attention, and then once that is done, you and your loved one decides to go to the primary care. When you go to the primary care physician looks at some initial labs. They do a MRI to make sure that there is nothing going on in the brain that could explain your cognitive complaints. They might do a cognitive screening test, and then they will refer you to a dementia specialist or a behavioral neurologist. Now, this is the usual steps that happen when someone needs to see a behavioral neurologist or a dementia specialist. Once this happens, the behavioral neurologist will conduct a detailed interview. They'll do another cognitive screening test, and based on their initial assessment, they will order most likely a neuropsychological or a detailed cognitive test, and also based on their initial suspicion of the underlying etiology, they will order other tests, which could be looking at the specific biomarkers. But you would be surprised to learn that from the point when people first detect cognitive complaints to the point of getting this dementia diagnosis or diagnosis of cognitive impairment by itself is about 3 years, which is a lot considering that dementia is usually caused by progressive underlying neurodegenerative process. That means that from the time that you first notice the symptoms, the time you go and see or you're able to see a behavioral neurologist, your symptoms might look very different. Your goals of care might look very different. But then the question arises, why is there so much time? And you would be more surprised to learn that this time could be up to 6 years for someone who has young onset dementia, or it could be more when you are on Medicaid, or if you come from underserved communities, or if you live in a rural setting. So naturally you ask the question, why is there so much delay in getting a diagnosis? It is really unnerving. Well, we will look at factors one by one that cause the delay. Number one, patient. So what could go wrong? Well, the patient might not perceive that there is any cognitive issue or there's any cognitive problem that they should be checked out for. Or there could be stigma associated with words like dementia, Alzheimer's. Sometimes individuals feel that this might be a reflection on how intelligent they are. Then there is low information or low awareness regarding these dementia disorders, and so sometimes people think that this is a part of normal aging. Whatever cognitive issues that they are noticing may be a part of normal aging, so they do not bring it to the attention of their loved ones or to their primary care provider. Now, caregiver, what could be the factors that could contribute to this delay? Well, caregiver is affected by very similar factors, just like the patient. Not perceiving the cognitive change, having the stigma of these disorders, Alzheimer's, of these words like dementia, a perception of what will even change even if you get these diagnoses from a doctor. Low awareness about these disorders is also contributing to the caregiver not picking up that something is wrong with my loved one. Now, here comes an important assumption. We are assuming that there is a caregiver. Sometimes people are living alone. There is no caregiver. Sometimes they're living with their loved ones and there is not an assumption of that role, because this is a very difficult role to assume. You are a spouse and suddenly you assume this role of caregiver. You are a child and you have always received care from your parent, and then the roles reverse and you assume the role of caregiver. So sometimes these dynamics, wrapping your head around it emotionally and to discuss it with your family, may also cause delays. Now, the delays can happen at the point of primary contact with the healthcare system, that is the primary care provider. Now, what can go wrong here? Well, when I was training, I did work in a primary clinic as a pediatric provider, and trust me, I really felt the pressure and the time constraint a primary care provider faces. Many times you're seeing a patient in a small time and they might come to you with 5 or 6 complaints, and it's really hard to address everything and to compress everything in a single appointment. So primary care providers face many challenges, one of them being the time constraints. They are dealing with every single medical problem you have, and something like cognitive disorders is very difficult, time consuming and complex to ascertain in a single primary care visit. Number 2, they might not have good relationships with a dementia specialist, and it might be something that they both have not realized that, well, we are functioning as a team. So the primary care and the specialists, who are usually in a tertiary care setting, need to meet, need to partner, and need to have this back and forth close feedback loop communication. But this is an ideal kind of thinking, and usually this is not present. So many times primary care providers do not know which kind of referrals should I send to this specialist and what would be an appropriate referral to be sent. And that may also cause delays in sending a patient to the appropriate specialist. Apart from that, usually our healthcare systems are fragmented. Again, what I was talking about, this communication and having this close feedback loop communication, this is usually not the norm. And what happens is that the care is fragmented. So because there is not so much coordination between primary and tertiary care, this also serves as a barrier for the primary care physician to confidently send their patients to a specialist. Now, what can go wrong at the point of specialist, which can cause these delays? Again, coming back to the primary care provider, where if you do not spend time establishing relationship from the primary care providers in their area, then your patients are going to suffer, because that will cause a lack of understanding in which is an appropriate referral, when the patient should be sent to you, and how comfortable are your primary care provider in communicating with you. Apart from that, the other issue that can happen with a behavioral neurologist or a dementia specialist is not realizing that there are a lot of community resources, and they can use these resources for the benefit of their patients. So these are the things that cause the delay in getting that care. And why is this important? Why are we even having this discussion from the standpoint or from the viewpoint of a patient and caregiver? Well, think about it. You're waiting, you have progressed so much that now, instead of being on the milder end of the disease, you're on the more severe end of the disease. And this means that everything changes. The symptoms that you were looking to get addressed, they might change by the time you see a behavioral neurologist. And you may say, well, that's okay. What is the big deal? Well, what happens is that as the person is progressing through dementia, these symptoms get more and more complex, and they become more and more difficult to manage. And secondly, it's common knowledge that earlier interventions lead to better outcome. And think about it. This is a person who's progressing, and in addition to them progressing, there is a caregiver, there is a person who has assumed that role and had come to terms with that role. So in addition to all of this happening, there is also, thirdly, the caregiver burden and frustration that increases during this time. And when I thought about it, the thing that troubled me the most, thinking about it from the perspective of a caregiver and caring for my grandmother, was the fact that the individual can progress so much that they might not be able to participate in decision making, in their future planning, which might be so important to them. So things like advanced directives, things like medical and legal power of attorney or financial power of attorney. So things like that. If someone gets a diagnosis of cognitive impairment early on, then they might be more proactive in planning these things, and they can plan according to them, versus you kind of are so late in diagnosing that this becomes another burden to add on to the caregiver, and the caregiver keeps debating whether this is what my loved one wanted, or should I do this or that, and this is often very difficult and leads to a lot of guilt and burnout for the caregivers. So all this leads for you to feel a little uncomfortable, and you're also asking, what is your ideal dementia patient care journey? So when I envision this ideal care, what do I think about? I think about a couple things. Number one, having a comprehensive model where all the care partners realize that they are a team and they work together. And we'll go into detail in terms of what are the care partners. Number two, we strategize and compress the timeline to see a behavioral neurologist. So there are two parts: strategize and compress the timeline, and we are going to talk about that first, and then we'll go into the multidisciplinary team. So when I talk about seeing a behavioral neurologist, imagine you're a family who has waited for, say, a year to see a behavioral neurologist, and the things we've talked about, symptoms have progressed, the caregiver burden has increased, you're frustrated, then you go and see this behavioral neurologist, and then, you have to do some tests, and once those tests are done, on a period of a few months, they see you again, and then they give you a diagnosis. But what if we have a care navigation team that is led by a nurse practitioner and a nurse navigator that sees the patient first, and it strategizes that time, that wait time that you have to see a behavioral neurologist. And secondly, to compress the timeline. So instead of having months to years, what if you can see the behavioral neurologist within a few weeks? And even when you're waiting to see a behavioral neurologist, you're not sitting idle, your care team is not sitting idle. They are assessing you thoroughly. And that is what I meant by strategizing that wait time. So say this is the referral, this is the T0 time point, and say this is T1, this is after a few weeks, and you're seeing the behavioral neurologist. Now in between this time, what are we going to do? So the ideal clinic could have the care team that meets with the patient and the caregiver, and they assess for the mood symptoms that the patient might be experiencing, sleep symptom that the patient might be experiencing. Now these are modifiable factors that affect our thinking and cognition, but easily modifiable. So why not screen for them early? Why wait for a behavioral neurology visit? What if you screen someone and you realize that they might have obstructive sleep apnea? Well, they don't need to see a dementia specialist to realize that they need a sleep referral, they need a sleep study to make sure that they're not having obstructive sleep apnea. So things like that would be completed during this time period. Now, in addition to looking at our patient and having that team effort, why not we also look at the caregiver and we ask the caregiver what is their level of burden and how much burden are they experiencing as a result of this new role or assumption of this new role. And if we notice that they are significantly affected, then why not? We offer them respite care, we offer them support group, we offer them other community resources even before seeing a neurologist. In addition to that, what we commonly see in our patients who suffer with cognitive impairment is that their balance is impaired. Sometimes they're having falls, sometimes they need other assistive instruments such as a walker. Sometimes they have problems with small muscles of their hands, like eating because they're having a tremor, or buttoning their shirt again because they're having a tremor, or other issues. And then there are sometimes issues with speech. There are issues with swallowing, which could be really scary. And again, my question is, this all could be a part of your comprehensive initial assessment, where you have a therapies need assessment, and depending on what you need, you can get a referral to a physical therapist, an occupational therapist, or a speech therapist to have evaluation for, say, if you have falls and balance problems, the physical therapist can help you with those exercises. If you're having problems with the small muscles of the hands, the occupational therapist can help you. If you're having swallowing problems or speech problems, the speech therapist can help you. And again, you don't need to wait to see a behavioral neurologist. And this is all day-to-day activities. This is all that is affecting you on day-to-day level, and if you fix them early, you can prevent falls, you can prevent swallowing and aspiration issues, which are the major things that happen to people who have cognitive impairment, and they lead to further progression of cognitive issues. Now, when we're thinking about strategizing this time and doing different things, another thing that you can do with the patients and the caregivers is to ask them, what are your goals of care? What do you want your behavioral neurologist to address? Because it would be really good to know where the patient and the caregiver are coming from, rather than assuming, oh, maybe they want the anti-amyloids. Maybe not. Maybe they just want to manage the symptoms well. Maybe they want to have a good quality of life. So everyone has their different goals, and establishing them early on with the care team is a great idea. Now, in addition to this, the other things that could be done in this early assessment is the barriers to care. So we could ask the patient and caregiver, what about this appointment, this setup was difficult for you? What could we change? What could we improve? And this could be things like, well, the transportation was difficult. Well, you have too many appointments, I got too confused, or someone did not explain to me what was going to happen. So maintaining this kind of good communication channel with the patient and the caregiver and letting them share what was difficult for them is a very good learning lesson for the care team to know. In addition, it is recommended that any individual who is having cognitive issues get tested for thyroid labs, vitamin B12 labs, and there are other blood tests that are recommended, as well as the MRI picture of the brain. Very often these tests are not done by the primary care provider for the reasons that we have discussed earlier. So why not use this time to have these tests completed if they have not been completed by the primary care provider? Now, the other thing that comes to my mind when I was thinking about this ideal evaluation and ideal dementia care journey was Very often you see a behavioral neurologist, they will do a screening cognitive test. Usually it takes about 10 minutes. It's either a MMSE or a MOCA. And based on that, they will say, well, you will probably need a more extensive neuropsychological testing. And this also takes about a few months, and then after that they see the patient, and that is also a big driver of the time of getting a diagnosis with your behavioral neurologist. So why not have an algorithm be followed at the initial meeting with the navigation team and have an initial screening test like MMSE or MOCA, and then based on the algorithm, whoever needs a neuropsychological testing, also that is completed before you see a behavioral neurologist. Now, this is all too much and this is all very idealistic thinking, but the whole point is that if we don't envision big dreams, we will not be able to achieve them. And so the first step is to think about the best, the largest, the biggest dream you can have, and then you can see where and how much you can get. And this can vary by institution to institution, place by place, but this is the whole idea. Starting from the referral to the behavioral neurologist visit, you do a mood, a sleep assessment for the patient, a caregiver burden assessment for the caregiver, a goals and barriers to care assessment for the patient and caregiver, as well as a therapies need assessment if the patient needs physical therapy, occupational therapy, speech therapy, or if they need a hearing evaluation. Again, that doesn't need for you to see a behavioral neurologist. If you're experiencing hearing problems, why not see an audiologist? And if you need, you can get a hearing aid. And we know that hearing issues are commonly associated with memory issues. For this, you do not need to wait to see a behavioral neurologist again. So having all this done in addition to the blood test, the MRI, and the neuropsychological testing, what this does for the behavioral neurologist and the patient and the caregiver is when you're meeting, you have all the data that you're requiring to make a diagnosis of the level of cognitive impairment. Now, when we make a dementia diagnosis, or when we are seeing patients in a cognitive neurology or a behavioral neurology clinic, we make two tiers of diagnosis. Number one, what is the level of cognitive impairment? Do you have normal age-related changes? Do you have subjective cognitive impairment? Do you have objective cognitive impairment or mild cognitive impairment? And do you have dementia? Once that is done, that sets the stage for further testing for etiological reasons of why you're having that degree of cognitive impairment. But this is the very first step that a behavioral neurologist does. And this is exactly what I'm talking about, could be expedited by doing all these tests earlier, even before seeing a behavioral neurologist, so that when you see the behavioral neurologist, we have the results of everything, and based on that, say the behavioral neurologist tells you you have mild cognitive impairment, and based on your whole history that the behavioral neurologist will also gather, they can say, well, I think you have these symptoms because of this and this pathology. Say they are thinking about Alzheimer's pathology or Lewy body pathology, or a combination of these two, and they might offer you biomarker testing so you can look at these abnormal proteins in your body, or they might say, well, the management of these conditions may not change based on your goals, so we can also start with medications such as cholinesterase inhibitors. Or there could be a major change in management if you and your caregiver are considering the new anti-amyloid medications like lecanemab and donanemab. In that case, biomarker testing would be very necessary. So that is why having the goals, having all this information at this appointment will facilitate a very directed discussion with the caregiver and with the patient, and you will have a written plan, which will be very well outlining and aligning with your goals and will direct the next steps of care and management. So this is just a dream, and I think dreams are often the first step to achieve anything. And this is something that I have designed and thought of in the past few months. And I've thought of from the perspective of a patient and a caregiver. And I think thinking about it in that way makes it very patient-centric, makes it very humane, and focuses on the individuals who are walking through the whole system instead of thinking through a systems way of thinking about any kind of medical condition or process. So hopefully this is an idea that makes people think more, question more, dream more, and innovate more at their own clinic. And it makes a difference in the lives of patients and caregivers like you and me. I'll see you in the next video. Till then, take care.